To be honest, when I was asked to talk on that topic, I was not really happy. I'm a pediatrician. I'm heading a department where overweight and obese kids are assessed and treatment is offered. So I knew I had 15 minutes, and I knew I was not going to be able to fulfill what I was hoped to do. So I will do my best, and we have time to discuss it. We are all aware of the fact that treatment is not prevention. And I ask you to keep that in mind when I now present these slides, that when WHO gave their report on how to tackle obesity, they defined the treatment of obesity as one out of 6 areas that are necessary to focus on. What are the hopes and expectations of our kids? Are we talking about a toddler that is severely overweight or obese? Are we talking about an adolescent? And if this is a 12-year-old, what is it that he's expecting or fearing when he is seeing us, or if his mother makes him see us, which is a very common setting in my experience. So Manfred, 9 years old, stated this. He said, "Could you please take that vast amount of food out of my head?" He said that in the second session to the psychologist. So he was very sincere, and he was very clear. He recognized already that he was plagued by that vast amount of food in his head, and he asked for help. The parents have their own expectations. Please make my boy lose weight. Inge, 39 years of age. So she was asking for help again because she couldn't handle the situation anymore. We're all aware of these changes of society, and Dave has already mentioned all the different drivers. Our societies are completely overwhelmed with these developments that have taken place during the last 30 years. And you're all aware of what we are facing. Look at these 2 pictures. This is a very common picture, and I do not extract myself from this. And as we enter into this complex scheme of childhood obesity etiology, we need to be aware that children grow up in the world of adults. In terms of eating behavior, we need to ask the questions: who enables a healthy diet and eating environment? There is food production, and we've heard and discussed this, and the food consumption issue. And the same is true for many aspects of physical activity that David will relate to. Nutrition is a central part of this bigger picture. And you've already seen one of the drivers is obviously consuming too little of the right and too much of the wrong. Philip James mentioned yesterday that men and women are obviously different, and they have different trajectories. And we need to be aware of the fact that boys and girls differ from the very beginning for different reasons, for genetic reasons, for environmental reasons. And I just pulled up 2 examples. They differ in taste preferences. And there is some data from the EGEA study supporting this, where fat preference associations were stronger in girls. They differ in certain dietary patterns, where in this large pan-European EGEA study, boys, and in particular older boys, consume the most amount of per capita total energy from sugar-sweetened beverages. So keep this in mind. On October 3rd, this paper was published in the New England Journal of Medicine by Antje Körner's group from Leipzig. And what they did was to prospectively assess 30,000 German kids who were seen by pediatricians and GPs. And for the first time, data are available from a large group of kids being analyzed prospectively. What you can see here is the prospective tracking of the BMI status of children into adolescence. Here in gray, these are kids that were underweight. In orange, these are kids that were overweight. In blue, normal weight. And look at the group that was obese in red. What you can see here is that at the age of 2 years, there is an uprise in the percentage of those children who would stay obese until the age of 14. In other words, those who were obese at the age of 3 years had an 80% likelihood of staying, which makes early intervention obviously imperative. And we've been discussing during our last session how to effectively evaluate the effects of treatment. And we know that there are the SMART goals. Goals must be specific, they must be measurable, they must be achievable, they must be realistic and timely. So this is something that we have to keep in mind. And we discussed this. There is no uniform standard definition of effectiveness. And for different reasons, we have been using BMI, and in pediatrics, BMI SDS, which takes into consideration age and sex. And we have been adding waist circumference over the years. Measuring fat mass is even more complex, but we have also been very rightly discussing that there are other effective outcome measures, such as the change in weight gain trajectory, improvement in obesity-associated complications, be it metabolic, be it orthopedic, be it mental, or the reduction in markers of risk of future complication. Now, if you look at the effectiveness in terms of BMI reduction, these are the results of a recent Cochrane analysis. And it is obviously necessary to integrate diet, physical activity, and behavioral intervention when we treat obese children. And this is the analysis of children who were obese between the age 6 and 11. And what you can see here is that there was some benefit in achieving small short-term reductions. The overall reduction in BMI was 0.5 kilogram per square meter, which relates to a BMI Z-score reduction of 0.06, which is not really much. But at the same time, you're discussing children where in many situations we are happy if the trajectory is changed. But if you have a look at children who are younger than the age of 6, you will see in another Cochrane analysis that the average reduction in BMI Z-score was 0.40, which is effectively 7 times the result of the kids between 6 and 11. So obviously, treatment is more effective the younger the children are. What are the broad principles of obesity treatment? Well, we are to assess and manage obesity-associated disorders. We are supposed to ensure a developmentally appropriate approach. It should be long-term. We're supposed to foster the increase in physical activity. Sedentary behavior is an issue. Screen time is an issue. Sleep has been mentioned. And in some patients, even pharmacotherapy, even in very seldom cases, or bariatric surgery needs to be considered. But in all this, dietary change plays a central role. And I will come back to this. The most important message is that it needs a multi-component approach with the family being in the center. The younger the kid, the more the family is the target, if you want. The parents are the target. In our setting, below the age of 8 to 10, we don't talk to the kids at all. We talk to the parents. And it is modern to talk about an individualized approach, which means, as Anne just mentioned, we need to know our kids. We need to know them metabolically. We need to stratify them according to the metabolic risk. We obviously need to stratify them in terms of their psychological profile and individualize their treatment. The main objective is a permanent change in the child's and the family's eating habits and lifestyle, rather than attaining rapid weight loss through low-calorie diet. But that clashes with the hopes and expectations of many of our families, because they want to see short-term effect. And many times, even if we consider a 0.4 reduction in BMI Z-score as being great, this is of disappointment for many parents, as their expectations are different. So we need to be clarifying expectations and hopes from the very beginning. A balanced and varied diet is recommended. And I've taken these following slides from a very nice summary and recommendation from the Italian colleagues that was recently published. And I like the fact that they attached grades of evidence to these recommendations. And they state that a low-calorie diet is not effective in the medium and long term, that the educational process needs to start with the assessment of the child and family's dietary habits. They recommend the use of food diaries. And we all know that food diaries have problems attached. It is a problem of underreporting, the problem of mal-reporting. Many patients see this as their stated bad habit report. So we have to be very careful. And there is people, experts in the field, who recommend using preferences, food preferences, instead of diaries, because you don't put the pressure on what is being done, but you rather focus on the positive alternative of preferences, which is easier to integrate. We can discuss this thereafter. Nevertheless, these are the recommendations, and usually diaries are compiled by the parents for younger children and done by the adolescents thereafter. Dietary advice includes the provision of 5 meals a day, 3 being main meals, no more than 2 snacks, to provide adequate breakfast, something that is not very common in many settings, to avoid eating between meals, to avoid high energy and low nutrient density foods, with sugar-sweetened beverages being in the main focus, and obviously to increase intake of fruit, vegetables, and fiber-rich cereals, plus to limit portions. And there's not enough time to go into strategies, but the portion size issue is a good example where you can actually influence habits by different approaches. There's different dietary regimes that have been discussed during the last 20 years or so. We have seen the fat reduction area, followed by the sugar reduction area, and then back. At the end of the day, these colleagues state that there are no randomized controlled trials examining the effects of different diets on the child's weight and body composition right now. And the conventional diet is actually recommended. Very low calorie diets are still broadly used, but because they are most effective in terms of BMI reduction, even they're not effective in the long term. But they might be used in severely obese adolescents in specific settings with clear supervision in specialized settings, but there is no RCTs in the medium to long-term range. These recommendations need to be put into practical advices, and the traffic light and modified traffic light system has been used successfully and has been shown to be effective, whereas reduction in caloric intake is achieved through categories of foods grouped by nutrient densities. Replacement meals are also very popular, and patients come and ask you, I've this shake at my fitness center. They sold it to me. If you ask them how much they're spending, it's quite a lot of money. What should we recommend in that respect? Be it drinks, be it a bar, be it a soup, they are not recommended. That's the bottom line, since efficacy and safety have not been tested adequately, in particular as far as the medium and long-term effects are concerned. Many of the studies that we look at, randomized controlled trials, are very special in terms of the setting, and they have not much to do with real world many times. So this is a very interesting paper that was published by a German group of clinicians looking at the average BMI decrease over time in 129 German treatment centers. And what you see on the left-hand side is the 129 centers and the effect on BMI SDS decrease after 6 months, after 12 months, and 24 months. And the large bar at the bottom, 60, 76, 83, 92% are the kids who were lost to follow-up. And only in 7% of these kids, BMI reduction of different extents was given. So this was depressive. But when you look at the right-hand side, they picked out the 5 best centers. And these centers adhered to quality structured with clear strategies in terms of screening, assessment, certification, training of the team. And what you can see is that these centers were much more successful than the average. So what does this tell us? It tells us that training teams having the right setting is effective. And we have to be clear that obesity is not something that can just be treated by everyone. You need training, and we who are here must spread these news, because they are news for many. I'd like to close with by opening the discussion. What are the future perspectives? Obviously, we need to focus on the preschool age, not only in regard to prevention, but also in regard to treatment. We need to transfer existing guidelines to local situations. That is not the fact around Europe. We have to implement multi-layered treatment services from primary care with specific tasks, toolkits that can be used within a couple of minutes, up to specialized centers such as the inpatient center that Anne has talked about. And certainly we need to implement the WHO action plan as the overall scheme. We are in a situation where we have discussed the involvement of adolescents already during these 2 days. There is studies going on, like the Co-Create study, that aims to integrate the perspective of adolescents into treatment. We need to very much focus on their own situation, and Andrea Vania has also touched upon this. There is e-health applications also in relation to dietary aspects that are on the horizon, that are not yet effective, but there will be opportunities to speak the language, to live, to become part of the life of adolescents, and by influencing them by a natural way, being positive, being in a way not teaching from above, but being their partners as we treat them. So let us join forces. The European Childhood Obesity Group invites you to have a look at the free obesity ebook. You might be the 1 million first one to have a look at it. It's a 3-year success story, 83 authors. And if you want, join us on Twitter, join us at our conferences. Thank you for your attention.
Thank you, Daniel, for this very interesting presentation, which is open to discussion, comments, questions. We have some minutes. Please.
Guest, Margherita Caroli, European Childhood Obesity Group. Thank you, Daniel, for this very comprehensive presentation. And I'm very happy because I see the dietary treatment back. Because for a while, the diet therapy has been hardened and considered as not useful or even dangerous. But the dietary therapy stay to the long-term treatment of obesity, like honeymoon stay to the marriage. It's a special moment in which children have to, and family have to change their eating habits and possibly need to lose weight. A different thing is to maintain the weight loss and new acquired eating habits. One thing that I never saw in considering the dietary treatment is the degree of malnutrition present in the family. I mean, we can have a different level of bad eating habits. So you can have a light one, medium one, or very severe one with a very monotonous diet with no intake of fruit and vegetables. And this happens because I see children that eat just, let's say, pizza, fried chicken, and so on. So I think that the treatment has to be tailored also according the level of malnutrition. It's a kind of rehabilitation. So if you just have been with a cast on your leg for 1 month, you don't need really rehabilitation to start to walk again. But if you've been 1 month with cast everywhere in your body, then you need rehabilitation, totally rehabilitation. And the dietary approach is just the same. There are people, family, they need the basic instrument, as you say, to understand what to eat and how much to eat.
Thank you. I mean, we need to apply a chronic care model. I think we all agree. And I find it very helpful to see the Edmonton scoring system. And there's other scoring system that, for example, has been introduced by colleagues from Berlin, categorizing children, adolescents into 4 categories. At the end of the day, risk stratifying them to their personal needs. And that includes knowing which dietary information to give in what kind of setting. It is completely useless to talk about diet to a morbidly obese adolescent who has a major psychosocial problem in this very situation. So we have to tailor our messages to the very individual situation, and diet is part of it, but needs to be introduced at the right time, in the right dose, with the right psychological background.
Another question? Maybe I have another question. Concerning this very important target period I talk about the preschool children. In practice, it's very important for the clinician to know that this is a very sensitive and very important period in order to try to change behavior of these children. Do you think this period is so critical because only for physiological reason concerning the weight gain physiology, or because this is also the case for all, if we want to change all behaviors in childhood? For instance, if you want to have children brush the teeth, maybe it's better to stay at that age, or it's very related to obesity.
We've already seen many discussions these 2 days that it is obviously something that is rooted already as early as during pregnancy and progresses during infancy. So that's a very, very sensitive period where metabolic programming is happening, but at the same time, food preferences and dietary habits are being shaped both by the influence of the maternal nutrition and so on. Those things have been discussed. So these things are there and explain to some extent why these kids, 83% of those obese, were already obese when they were 3 years of age. So yes, intervention early seems to be even more important.